All right. Believe me, why the neuro there is no pathogenesis, no drugs, which is basically no treatment. Usually, treatment is not so high yield because a lot of neurological disease, no treatment. The important thing is to diagnosis. But why it's hard? The problem is it's really a chapter designed in or maybe the disease designed in subcategorized way. I mean, he will, for example, seizure, and then headache subcategorized into 1, 2, 3, 5. Seizure 1, 2, 3. These seizure crazy partial, whether complex, whether generalized, whether absence. And then you'll go to topic which is movement disorder, which is really very hard. Like, what is this dystonia? What is this Tourette syndrome? What is tic? What is dyskinesia? What is akathisia? These are just crazy. And so you have a lot of small, simple stuff, but although they are small, but by definition is not easy. And then you will get to big topics, which is dementia. Maybe more than 10 causes of dementia, and you don't know how to classify it. Some people classify it according to whether it's infectious, endocrine, and this stuff, but this is not helpful for the test. And then you went yesterday with vascular, and vascular also not easy, although I didn't talk about all details in vascular, because when you'll do guys U-word, you will see vascular details usually half of the vascular details location, which is basically whether anterior cerebral artery or anterior or Pons lesions or whatever. And then you will see maybe another half by half, which is basically investigation, which is big deal. When you will do carotid, when you will not do, what is the advantage of that? So that's a lot. And then maybe even you will go with tumor. I don't think is high yield in neuro. What I'm trying to say, these kind of subjects that they have a lot of subdivisions per each topics, like this movement disorders, maybe 10 subdivisions, like dementia, definitely more than 10, like a tremor, by the way, around 4, like ataxia causes around also 10 causes of ataxia. It's just crazy, which is basically gait disorder, right? So that's why it's kind of not easy really to make. It need just approach. Whenever you will see, let me just add Fatima. Whenever you will see a topic or topics like this, what's going on here? Yeah, because I thought it's my fault. Do you hear that now? No, right? Now is it clear? No, no, I think, let me try again. I think I just added Fatima and I hear this. It's weird. Anyway, yeah, it's not responding. So that's why, guys, when you go and see these kind of topics in medicine or in gynae, try to think what's going on and try to make it in a different way. I know it's not easy, but you cannot really get good score or understand what's going on with these too much subdivision, and each one of these subdivision just one or two line, so you have to go and to make something in common, and then you will make another subdivision. So, by the way, this is even in life. Always try to go to the common things, and then you will go from there. And you will see here how we will do with dementia. So I will start with dementia because I think this is the hardest part, at least for me, in neuro. I remember I get a lot of dementia questions. It's really make me crazy in the test. Dementia and psychiatry. It was big time, and I didn't study psychiatry well because I hated. So really, I had hard time with these two topics. Oh yeah, yeah, in step two, I because I didn't study psychiatry in step two because I was already bad in step one, so I decided I will not study it well, just study a few days. So I got a lot of psychiatry, but I get the same score in step one in psychiatry, so that's mean nothing. I didn't improve in psychiatry, but really I got a lot of neuro. It was just crazy, a lot of neuro questions, especially dementia stuff. Anyway, I didn't find Fatima here, so let's see. So guys, how we'll approach it? I will give you one hint for each thing, for each dementia, and then you will tell me the diagnosis. But before I will give you a hint, I heard some background noise. I don't know from which side. Do you hear guys background or are you fine? Just you fine, Yvonne? All right. Okay, okay. Oh, okay. Cool. That's my fault. Anyway, guys. So behavioral dementia with behavioral changes. I will give you some just keyword. Okay, let's make sure we use. Hopefully, we will use universal color. Sorry, yeah, let's act fast. So, guys, dementia with behavioral changes. Give me differential diagnosis. Behavioral changes. Maybe personality is important here. So behavioral. I'm not sure about the spelling. So someone said Alzheimer's. I will buy it, make it number one. What else? So AD, guys, by the way, AD, not autosomal dominant. This is Alzheimer's disease. What else? No, vascular is not here, not under the category of behavioral. What else? Huntington, yeah, you are right, but I will not make it here. Pix is uh, frontotemporal dementia. I'll put it here. I'll buy it, which is basically Pick's disease. What else? All right, maybe that's good for you. There are another two. Hey, hey guys, I hear background noise, please. I hear someone walking. Yeah, now it's better. So you get two: Alzheimer's disease, Pick disease, usually behavioral. And then you have another one, which is here. I know it's hard to make it, but we will add it later. So the second approach to dementia is dementia with movement problem, movement disorder. And any movement disorder, either the patient is just slow or the patient is rapid movement. So dementia with movement disorder and the movement is a slow movement. Okay, I don't want to make bugs. So Parkinson is one of them, so we'll make Parkinson here. So what you will add to make it Lewy body dementia? So you are talking about Lewy body, you mean? What you will add here to make it Lewy body dementia diagnostic? Very good, which is visual problems. So you will add visual hallucination, which is very key, which is really a key point, guys. So this is dementia, primary motor disorders, and it's slow motor disorders plus visual hallucinations. Now you will get into Lewy body dementia, which is basically due to Parkinson's disease. So you're fine. Second, dementia, movement disorder, but the movement is rapid movement. Now, what I mean by rapid movement, also you have two differential, whether choreophore movement, and you have 5 choreophore movement. We'll talk about these in details. So your diagnosis will be now easy. Yeah, this is Huntington disease, right? So you're done with Huntington here. You're done with Lewy body there. Rapid movement, but the movement is myoclonus. And the dementia really is rapidly progressive dementia. So you can add here in the red as rapidly progressive dementia. This is the only rapidly progressive dementia that the patient die within 6 months. Very good. Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease. So you can put it here, right? So far you get 5. Primarily behavioral changes, you will do Alzheimer's or frontotemporal dementia, and I will tell you how to differentiate it. Dementia, guys, don't forget. So it is still dementia. It is still memory problem. So dementia is memory, start with, but the plus slowness, Lewy body, but remember visual hallucinations. Rapid, you have 2. If there is myoclonus, this is usually only features or diagnostic for Creutzfeldt-Jakob disease, chorioform Huntington disease. Now what else? So this is we done with the movement. Now we will go to the other category, which is basically feet problem. And I make it feet. I didn't make gait, but I make feet just to make it more fun. Now what I mean by feet problem, which is basically gait. Or we can differentiate it into gait abnormality, and we will put gait here. Why? You have 2 gait problem in dementia. The first one, wide gait. Wide gait in dementia means, anybody know what I'm talking about? That's interesting. It's not come to my mind. Okay, okay. So in this case, I think I will make the wide gate into 3 differential, because usually I made it 2, but because you add the alcohol for me, so I 3 differential. And look, each one of them there is some other stuff. Okay, sorry. Let's make it more. I know it's too much details, but it's interesting. Once we'll be done, you will see it. So someone said alcohol. So basically, with alcohol, what you need? You need the wide gait, and you need maybe wide gait ataxia, and you need confabulation, right? So in order to say this is Wernicke encephalopathy, right? So alcohol will be here. Now, one of the wide gait, which the one that I need because it's more important, it's wide gait plus urinary. Very good. So this is normal pressure hydrocephalus. So you get normal pressure hydrocephalus is urinary symptoms, wide gait dementia, guys. Don't forget we are talking about dementia, so we are talking about memory. So you get MPH, you get alcohol, and finally, if there is any sexual history, and you will put it in neurosyphilis here. All right. Now neurosyphilis, one thing it's important. I think you can put here in the red as personality. And because I did personality there, that's why you can add neurosyphilis also here, which is behavioral. Okay, so neurosyphilis can be presented as behavioral problem, which is personality problem. Plus, it's really weird. The presentation: tremor, dysarthria, headache. I don't know how to memorize these in neurosyphilis. Tremor, dysarthria, headache means non-specific for me. The specific things I think for you guys you need to know it's wide gait plus personality change. Now I'm talking about the gait, so you can add here basically shuffling gait, and you can make it the second gait disorder, right? And shuffling, which is usually this the neural step gait of Lewy body of Alzheimer's disease. So you get 2 differential diagnoses of the gait here, which is nice. Now, I'm talking still about the feet with burning sensation, and it's very easy, which is peripheral neuropathy. And the only time that you have peripheral neuropathy with dementia-like pictures, it's vitamin B12 deficiency. All right. So what next? Any vascular dementia or the problem with the vessel, you have to differential. You remember, guys, yesterday when we talked about vessel, either infarction or hemorrhage. So if the patient have a lot of risk factors, you will go with this. You will put here risk factors. That mean hypertension, old age, cholesterol. So I'll put risk factors there. And then finally, I'll put what type of dementia, which is a lot of vessels problems or hypertension, old age, diabetes. No. You mean multi-infarct. Multi-infarct dementia. Alright, subarachnoid will not present it as dementia, but maybe you mean vessel and patient older age. I don't know if this is specific, but let's say this is older age and also vessel problem. So in this case, you will go with hematoma. And hematoma, I mean dementia due to hematoma, it's two, but usually subdural hematoma is important. Alright, so you can put subdural. I'm not sure about epidural, but I remember subdural hematoma, one of the differential diagnoses of dementia. So I think that's not bad. This is, guys, you will go with your word, and you will go even with the test. You will surprise. Maybe you will not get dementia. You know, some people get a lot of dementia. Not some, it depends. For me, I got a lot of dementia questions. I don't know why, but my friend got a lot of cardiovascular questions. So it depends. I don't know how they will do that. Now, I will add two differential diagnoses, guys. Slowness means the patient is slow in general. So give me different dementia that you have, that the patient have is slow and obesity. What do you think? Make it like this, green. Slow and obesity, patients really slow, weak, obese, constipation, fatigue, decreased tendon reflexes, maybe hypothyroid, right? So you put hypothyroid here. Then another differential, don't forget, choreiform, which is Huntington disease, there is really major depression here. So you can add, okay, let me add it in red because we agreed on. So here, depression. Now, so here you also can put differential diagnosis of depression, which is also presented as dementia. So you can add depression. What is the other depression that's presented as dementia? Pseudo dementia. So you can add here pseudo dementia. So depression and dementia, I think you have two or three differential, guys. The first one, choreiform, which is Huntington disease. The second one, pseudodementia. The third one, I just remember it. This is one, sorry. This is second. And this is the third. Third one is HIV dementia. All right. HIV dementia. And I like to add HIV dementia in any differential diagnosis of sexual problems in the past. So it is sexual, which is basically, that's why you get neurosyphilis. So you can add here differential diagnosis also HIV dementia. All right. I know it's not easy, but I mean, these you have to study like this, and when you will see a lot of crazy categories and you don't know how to make it. I think now is at least easier. Why? Because you will just go with the hints in the question. So if he's talking about gait, you just need to know exactly where are you in this diagram. All right, where is your location in this diagram? which is basically either wide or slow. So you have Lewy body. So let's repeat it quickly. So we get Alzheimer's disease, this number one, which is the most important. You get Pick's disease, which is frontotemporal. You get neurosyphilis, which is also interesting. You get Creutzfeldt-Jakob disease. Don't forget, this is the only one rapid, which is very, very, very easy. The patient will die within 6 months. So it's very easy to make it. And it's the only one myoclonus. So you don't need to get this wrong. Huntington disease is also he will give you a lot of hints. Maybe CIDO is a kind of hard because you will forget it. Lewy body here, I don't know how much this number. It is not MPH. No, yeah, it's a normal pressure hydrocephalus, right? Neurosyphilis, again, I repeat it. Alcohol, vitamin B12. I don't know. Look, it's really a lot. Multi-infarct dementia and subdural and hypothyroid. All right, guys. Now, any question before I will go to details? I have to go to details of this. This is not a detail. This is just, big slide. And I will give you clinical cases to tell me what's going on with each one. Any question? All right. Yeah, guys, now it's good. Now I didn't hear this background noise. Okay. So ready? So we'll go to clinical cases. Age is important in some dementia. So when I will not write the age, that means it's not important here, which is, so if I will not write the age, that means I will assume it's older age. So it is the patient have some kind of behavioral problems. What is the behavioral problems that he have here? Maybe he is euphoric. Sorry. So this is, oops. So this is the first case. Maybe the patient is euphoria. Maybe the patient using dirty language. So he has a problem when he's talking. And he's really in disinhibitions. That means he's kind of compulsive behavioral he is I don't know, has a problem with eating, so you can say peculiar eating. So in this case, you know what I'm talking about, guys. The diagnosis will be right away. Maybe language also. Yeah, we talked about language. So the diagnosis will be right away. What is that? Quickly. Now, frontotemporal dementia. Do you think there is family history here in frontotemporal dementia? Yes. So family history is positive in frontotemporal dementia. Diagnosis, what is the diagnosis here, which is also not so hard, is MRI. And the MRI, what you will see in the MRI, this is the brain. You will see really big ventricles around the frontal area, but the ventricles here down is normal. Why? Because from the name frontotemporal, that's mean the atrophy is here. That's why this is the problem. So frontotemporal atrophy. So the problem is just behavioral. And remember, the second thing about the behavioral is what? The family history report. Any visual problem? No. We talked about visual. There is no visual problems in Pick's disease or frontotemporal dementia. The second one, patient now is alert. This is interesting. He's alert and he's fine, but after a few days, the alertness is decreased. So alert, you can say positive, negative, or alternation. So alternate in alertness. He's not always alert. This is first. He's slow, as we talked about. He has a visual problem, and this is the only dementia that he has visual hallucinations. Visual hallucinations. Now the second question will be, what is this kind of dementia? And I think you know what is that quickly. Now this is easy, which is Lewy body dementia. So you get the diagnosis at least of Lewy body dementia, which is shuffling gait, memory problems. So you're fine with that. Now, what you will find in Lewy body dementia, what is the organs that affected? Because here we talked about frontotemporal. Give me the organs in Lewy body dementia. That's just no. Lewy body means a kind of Parkinson. So you get a problem with substantia nigra. This is first. Locus coeruleus, which is this nucleus in midbrain, right? What's the problem with these cells? It's degeneration. So basically degeneration pathology. So you will get here degeneration. And what you will see in histology, you will see this cytoplasmic inclusion body is called like this, called alpha synuclein. Synuclein. So you'll see this, which is this is the Lewy body in general. So this basically it's intracytoplasmic inclusion called alpha synuclein. I hope I write it right. Alpha synuclein protein, where either substantia nigra or locus coeruleus. So you get substantia, you get locus coeruleus in Lewy body dementia, while you get frontotemporal problems in Pick's disease. So this is so you have to know, guys, the location, because he usually do that. I don't know really, but he usually does that. He will not give you the diagnosis. He will give you is substantia nigra region or temporal lesion, so you will know from the location that what he's talking about, which is usually the same case in step 1. So he's, I don't know, Fatima, I think she's struggling with internet. So you find now Lewy body. Now there is a trick here, how you treat it. This is important because there is a trick in a treatment. How you treat this Lewy body dementia. What is the drug that you don't need to give it to those patients? What is the drug that contraindication in those patients? Okay, 2 modalities of the treatment. Yes, guys, 2 modalities of the treatment. The first one, don't give no to which drugs? No neuroleptic drugs. So neuroleptic drugs, neuroleptic, you know neuroleptic well? Neuroleptic, those drugs that antipsychotic. Hey, are you fine? Please, the one that he just joined or something, can make it mute. So guys, neuroleptic drug, just basically these are antipsychotic medications, and these are anti-dopaminergic medications. All right. So these